Hi, I am Dr. Jerry Hesch, an orthopedic manual physical therapist. Got a bachelor's degree in physical therapy, and then I got a master's degree, and then I got a clinical doctorate, okay? Our topic here, that's foot with the cuboid being in red because it's hurting and not moving normally. The title is Cuboid Syndrome Advanced Treatment. Cuboid syndrome involves pain on the lateral aspect of the foot. The fifth metatarsal bone kind of flares out, so there's a very distinct bump there. And so if you move your finger on the outside of your foot and then you fall down, you're touching the cuboid. It's quite a big bone, so it's really easy to put your thumb under it and your finger on top of it and test mobility. Well, the cuboid bone moves with the rest of the foot and ankle. And the cuboid connects to the heel, called the calcaneus. So comparatively, the heel bone is much bigger than the cuboid. So it greatly influences mobility of the cuboid, and so if the heel bone has lost movement, your cuboid has lost movement. And whipping the cuboid might not fix the problem, okay? The heel, looking at the back of the foot, the heel moves left and right, okay? But a very important movement, it also twists left and right, okay? So if we're going to treat the cuboid, we need to treat the heel, the calcaneus, and make sure those four motions are moving normally, okay? Another bone in the midfoot greatly affects the cuboid, and that is this one called the navicular. Well, the navicular connects to a big bone, which is the ankle bone called the talus, T-A-L-U-S, okay? So the talus can control movement of the navicular, and people who have restricted rotation, pronation, supination of the navicular will have a restricted cuboid. So I treat all of those, and I also test all major joints in the foot and ankle. It's an integrated approach, but it's also within the context of a whole body approach. And the hip can have a significant influence on the genesis of cuboid syndrome. Now, we're going to look at my skeletal model here. And this happens to be a right foot, so I'm going to walk around the table and focus on the right side. Okay. An important movement is that the ankle be able to dorsiflex normally. And if it doesn't, then that can contribute to cuboid syndrome over time. The most common pattern of cuboid syndrome is what's called a supinatory pattern of the foot, opposite of a pronatory pattern, and it's a very rigid fixation of multiple joints in the foot and ankle, not just the cuboid. So there's a very wise saying, which is, do not treat where it hurts. With cuboid syndrome, that's very important. In the last year, I did have to directly mobilize someone's cuboid, but most of the time by integrating all the other joints all the way up to the hip and pelvis, oftentimes the cuboid is very happy once you restore those movements. So anyway, moving up into the lower leg, we need to make sure that the lower tibia has not glided forward and become stuck. We need to make sure that it can rotate internally. There's a very small amount of play, very small amount of movement there that is part of transmitting forces from the femur down into the lower leg, down into the foot and ankle, okay? And then the top of the tibia should have normal external rotation. Distal femur, thigh bone, should have normal internal rotation. And then that brings us to the hip. Now, the way I like to test hip motion in terms of rotation is I capture the whole leg and I do a log roll. And I roll it in. And that movement is reduced in a fair number of adults, and I blame driving the car. The way that we use that leg on foot and brake can contribute to that. We also function in a right-handed world. It kind of promotes that. Now, some people have a normal movement there, and you roll it all the way to the end. You should be able to give it a little bit of spring. It should spring and recoil, and that's normal when that happens. But I developed another test that is a precursor to that motion becoming restricted. And it facilitates weight bearing more on the outside of the foot, promoting cuboid syndrome. And that test is that I come behind this bump on the outside of the hip, and there's your hip joint right there, ball and socket, and I lift it up. Or if they're on their stomach, I spring it. And oftentimes that motion is restricted. And it might have to do with a very low hip rotator muscle, a big one, big strap, called the quadratus femoris. And I have a very effective treatment. And it's also important to restore normal mobility of the pelvis, normal posture, normal mobility of the pelvis. A lot of people call that sacroiliac. But the sacroiliac joint only moves a little tiny bit, but the whole pelvis moves a lot with the lumbar spine and trunk, and it moves a lot if you're standing. If I'm standing, I can twist my hip, I can move my pelvis a lot. That's not my sacroiliac driving it. That's this big ball and socket joint that has a bunch of movement. So I'm very careful about language. I think we need to be biomechanically precise. And now I'm going to grab my little foot model and come back, and we'll wrap up shortly. So when it is necessary for me to restore mobility of the cuboid directly, most of the time, because it's stuck in supination, it needs to come down. Remember, this is the right foot. The cuboid needs to come down to the ground and rotate medially and glide medially, effectively dropping the arch. That's called pronation. It's a normal movement during gait. Okay? Less common is when the cuboid is dropped down. I've actually had both types in the same ankle 30 years apart. So it made me very wise about, yes, it can go both ways. But a cuboid that's stuck in pronation and it doesn't glide up and out and laterally, that one's very effective if you've corrected the movement in all the other joints that we spoke about, all the way up to hip and pelvis. Then there's an effective technique where you bring the foot downward and you give it a thrust called a cuboid hit, cuboid whip. And there's also a squeeze technique. So realize that the cuboid can get stuck up and out and laterally, and it can get stuck down and medially and glided medially. And we need to treat the whole system. And the treatment that I do on the hip is very effective, as is the treatment for foot and ankle. And typically it's 2 visits, not more than 3 visits. And once you restore all of these movements, then when the person walks, the whole foot and ankle finds that normal pronation, normal supination. It can go into supination without getting stuck. It can come right out of it. And then we do teach some very simple self-treatment should it ever get stuck again. And we teach very gentle movements to kind of support that and prevent recurrence. So I would say that cuboid syndrome is a little bit more complex than what the literature promotes. and weekend workshops where people learn to manipulate it. It's just part of the story about how it can misbehave. And it's for some people, it's very effective. The literature supports that, but there are cases where it doesn't work, and a more global approach within a whole body context is very effective. And if you wish to come see me, you can see the information on my website on this YouTube video. The spelling of my name is important, and my website is Hesch, that's my last name, Hesch Institute, okay? The spelling is H as in Henry, E as in Edward, S as in Susanna, C as in cat, H as in Henry. And I've saved people a lot of money who have been spending lots of money trying to get their cuboids resolved. And my favorite case was a guy that was retired from the Forest Service, loved hiking, loved horseback riding, had to quit both of those for 3 years because of cuboid syndrome. And he was just absolutely delighted. And we did treat the whole body with his presentation. And now he's happily enjoying his retirement. I have other case studies on YouTube. And thanks very much.